Hello, everyone. I'm just going to give it a couple minutes for people to log in, and then we'll get started. I guess the last session of Connexion, virtual Connexion this year. We got some echo going. I hope we can control that. Our subject matter today for this panel is margin expansion, profit stabilization, and building a competitive edge in healthcare. And in a moment, I will let each of our panelists introduce themselves. I was a little taken aback when I was asked to moderate this. I've got this panel of esteemed financial personnel. I am the CEO of a mid-sized medical practice. I have not balanced my checkbook ever. I don't do the finance end of this, but for some reason I've been asked to moderate this. So we're going to rely very heavily on the panelists here to talk us through. Let's just start and do a quick introduction, and I'll start. I am, as I said, the CEO of an 80 provider private practice medical group. We are unaffiliated, although we have, we do admit to and work with predominantly one hospital system. It's the Trinity system in New England. And I am going to turn it over to Gary, who's on my upper left of the screen, and ask you to please introduce yourself.
Thanks, Susan. My name is Gary Simkis. I work for UHS, which is a for-profit healthcare system, which is made up of kind of two arms, a 200 facility BH arm and a about 27 facility acute care arm. I am the Vice President of Financial Analytics and Systems over the acute care side, along with the interim CFO of the 500 plus physician practice that supports the acute care division.
Very good. Max.
Hi, I'm Max Owens. I'm a Senior Vice President and CFO for a small health system in South Central Washington State. Been here about 3 years. Have overall 42 years in healthcare finance, large, medium, small, for-profit, not-for-profit, standalone, and system players across the United States.
Excellent. And Ken?
Yeah, Ken Hendren. I'm a CPA licensed in Tennessee. I've been in healthcare since the early 90s, first in the clinical side as a respiratory therapist, and then made the move into accounting and finance. I've been a CFO and healthcare finance for about 20 years.
Very good. And Sandy, I know you just got off of another call, so thank you for joining us. And can you introduce yourself, please?
Sure. Hi, my name's Sandy Weiss. I'm the Executive Director of Finance for a county facility in New Jersey. We're Safety Net Hospital. We have about over 1,000 beds, primarily behavioral health, substance use disorder, acute, and long-term care.
Very good. So this is going to be very institutionally based, and I think that's what a lot of our audience is, although it's hard to tell on a Friday afternoon who we have in an audience, especially on the way these panels are set up. But hopefully there's some people out here, and I'm certainly going to benefit by listening to what you all have to say. I think it's always trite to say that we face challenges in healthcare, in any industry, but in healthcare, really. I mean, as we are facing the mounting pressures of increased staffing costs and increased costs of materials, and then fighting with managed care for a 2% increase which can't even cover. We've got shrinking margins, and we're asked to do more with less always. So we're going to hit on a couple of different topics today. As I said, I am not a financial person. In fact, I'll tell you one other quick anecdote. Today, I was trying to help out our finance department because we're short, and I went to pay the company American Express bill, and by mistake, I hit it into my personal account, and I didn't have 158,000 in my personal account, and it bounced, and it's a whole mess now. And the finance department basically said, "Thank you for your help, but we'll take it from here, Susan." So anyway, I'm probably going to shut up during the rest of this and listen to you guys. But I want to approach it in sort of a couple of different ways. First, we have to talk about the cost control, waste elimination. We have to talk about efficiencies and things like that, and strategies and tactics and things that have worked for you. We'll hit the hot topic of labor, right? Because I think in no matter what industry you're in, but certainly in healthcare, the issues with labor and what's been going on, particularly since the pandemic and the echoes of the pandemic are haunting us. But then what's really exciting to me as a strategist by training is we're going to talk about growth and new opportunities, and how, faced with all of these mounting pressures, we use growth as a strategy to stay afloat or to get ahead. And then finally, if we have some time, I'm going to ask you all within your organizations how you work as a leader to get buy-in for these things that we're talking about, because I think that's important. It's very nice for people to sit here and listen to a panel talk about all these wonderful things, but how did you actually get to implement, or how are you implementing? So let's jump in with some cost control, and I'll throw this out. The first person that unmutes and talks is it, and then we can talk amongst ourselves. Talk to me about strategies or specific tactics you've used with regard to cost controls or efficiencies that have worked particularly well. Max is unmuted, so I think, or at least on my screen, so I'm going to pick on him first.
That's okay. I tell you, we had some struggles with traveler costs back in 2022 to the tune of, running us into the red and driving the company, under. We were paying $225 an hour when our normal for RNs $34 to $45 an hour, and you're paying $225 for a contractor. You have a bunch of them, and it doesn't take long to get out of control. So there were a couple of things. We had 3 phases to our plan. The first phase was really, we actually reduced services and reduced demand for contract staff. I know that sounds contrary to let's grow volumes, because if you grow volume at $225 an hour, you're not going to make money on it. You're going to lose margin. So we actually shuttered beds and de-staffed areas of our facility. We closed a cardiology service. We closed an OB program. We downsized 8 beds, and we de-staffed another 40 beds at one of our hospitals, and said, I can't control the hourly rate. I can't control, what it costs us, but I can control the demand for contractors. So we eliminated a bunch of contract staff by de-staffing our services and closing services. And at the end of the day, it saved a boatload of cash. The second phase to that was we created a friendly company that did staffing for us, and it took out that market margin that the staffing companies are getting. So instead of paying $140 an hour, we could pay $75 an hour to the employee, to the nurse, and still only end up paying $104 overall. So we saved that $36 or whatever it was, margin to the IAs of the world and to the, medical staff companies. So we were saving margin on an hourly rate. And so we were able to decrease hourly rate that we were paying for the staff we had. We just had to convert them from a contract staff to this other company. And that was primarily not converting them. It was going out and finding new travelers or new staff to put in that company. And then the third phase that we were doing, because we had 3 legs on this particular stool, was to grow your own. So we created our own nurse tech training program. You get seniors that are in nursing school. You put them as part-time staff in your hospital. And they have a 2-year commitment once they get licensed to work for us. And we've been able to hire about 10% of our nursing shortage through that model. And that is continuing to grow. And we're pretty excited about that model. It seems to be working out quite nice. You end up with brand new nurses at the lowest pay scale instead of bringing in nurses at the top end, the seasoned nurses. You do have to make that kind of an issue for your CNO and some of the nurse leaders. They don't always want, new grads. It's hard to get a new grad in the ICU because they just don't have enough experience. So having the training program on site, they get to be accustomed to the hospital, they get to know the facility, they get to know the nurse leadership, they actually do nursing care as trainees. They might be an aide, they run around as an aide. So they get exposure to the hospital and they get used to it, and we get to know them. And it's pretty easy to pick them up as a new grad once they graduate. So those are the three that we've done in particular on contract staffing costs in general.
Max, would you say staffing costs were the biggest sore point or hot point for you in terms of cost containment and
It was, it was absolutely out of control. We had 1 month where we had $3 million in contract labor on a budget of 500,000. It's going to just blow you out of the water every time. We're now running about $400,000 a month in contract labor. So over the last year and a half, we've been able to cut pretty substantially in our contract labor spend.
Max, were you able to bring back some of those service lines or reissue some of those beds that you had kind of put on pause?
We have reopened the majority of those beds. And actually for one of our hospitals, it's a critical access hospital, so it has additional reimbursement. We went after Medicare and said, we want interim rates that will increase it. And then we were able to staff some of those beds that we had closed. We have not reopened OB. That's like a $10 million price tag to reopen OB. Can't do that. We're not going to reopen cardiology anytime soon. But we did start reservicing most of the community.
let's continue on labor. And we can go back to other costing, but who else has done anything innovative around labor? Because obviously it is a sore spot, whether it's a little practice like mine or a big hospital or a system.
So go ahead, Sandy.
So one of the things that we did, because labor and agency, blew our budget, completely blew our budget. So a couple of things that we have done, we haven't closed any programs, but our biggest gap right now is CNAs, because we have the long-term care facility. We are desperate for CNAs, so we started a CNA school where, whatever division of the hospital you're in, you want to be a CNA, we pay for it. It's done on site and it's affiliated with the state, so they can get certified through us, and then in the hopes that we keep them. Another thing that we've done is connect with our local community colleges for respiratory LPNs, and as they're graduating, get them to come here. Last year we developed an apprenticeship for electricians and plumbing, I think it was, because they need so many hours under a certified electrician. So they come in, they kind of be like, the support, and then they can get their hours for what they need to get certified as an electrician. The other thing we just started is we also lack in LCSWs. That's a big, licensed clinical social workers. That's a big one that, especially for the patient population that we serve, it's hard to find. So we have hired LCSWs, and we pay them to supervise our LSWs. So you could be a licensed social worker, you got to get clinical hours. We pay you to work, and you get those hours, and then you can sit to become a clinical social worker. And each LCSW who can supervise, I think, can supervise up to 6 social workers, licensed social workers. So it's kind of helping us build and, hopefully try to take away from some of the agency.
Sandy, are you successful in keeping them after? Are you keeping the good ones? Are they staying with you?
The LCSWs we just started, and it's so far so good. The apprenticeship started last year, and I think it's about 2 years. And we did keep some of the CNAs. I believe they are going to start the school again, but we cover it, so it's great for anybody who wants to try to step up and maybe move to an LPN and an RN. We've increased our tuition reimbursement in an effort to encourage people to if you want to be an LPN, you want to go be an RN, in an effort to try to, help cover some of the costs.
Yeah, very good. Gary, what do you got going on?
I feel like Max and Sandy hit on some of the key points here. I would just reiterate, I think our primary focus at the height of the pandemic and coming out of it was really working those contracts that we had with the traveler nurses on trying to get renewed rates at the lowest rate we could. So not contracting for as long anymore, but keeping them as short as we could so that we can get a new lower rate and really bidding that out to get that down. I think the team's done a really good job. It's still higher than what we ran at in 2019. And that's kind of been our benchmark, is how do we get back to 2019 staffing levels? I feel like things are elastic, right? But this one is almost stretched to the point where it doesn't really seem to want to go back in the same shoebox that you once had. I think one other area that we concentrated on was focusing on international nurses. And so to everyone's point, traveler nurses was one area, but bringing in some of the internationals, we've had some really good success with some agencies and placements where it's like a 2-year stint that they stay on for the time being. And they've been very skilled nurses, and we've gotten a lot of good patient satisfaction notes and scores from the population. And it's almost a little bit like a whack-a-mole, right? You concentrate on the agency, and then the labor shoots up somewhere else. And so the focus has been on some of our overtime utilization, right? And looking at, okay, how do we run in terms of overtime hours as a percentage of total productive hours, back in 2019, and trying to implement those same practices in 2023 and beyond. And so we started focusing, instead of trying to boil the ocean and manage everything, we just started really last month sending out a top 10 in terms of our top 10 RNs that are over that benchmark in terms of utilization. We call it our high earners report. And we send it out, by employee, by time department, because sometimes nurses work on different shifts. They get pulled in different areas, and one department manager may not realize or even have access to see some of their utilization of hours just in their own department, maybe not hitting overtime, but having them work in a different area, it puts them into an overtime rate, if you will. And that rate is substantial. Even it's higher than the normal per diem rate that you would pay somebody at $65 an hour, right? So really trying to concentrate on and focusing on those top 10 can almost reduce 50% of your overtime utilization if you manage those top 10 from what we saw, because it's just kind of some poor habits, right, that we all got into during COVID, just trying to fill holes, right, and just trying to get back to practicing the way we all did when we weren't so stretched, if you will.
Yeah, it seems like our own staff, they're easy to go home and not want to work. The travelers are there to work, so they'll pick up any open shift, including overtime, unless you control it, because that's what they're there to do, is to work and make a lot of money. Your own staff are taking off, and I'm going to go, and then your automatic first fill is traveler.
Right. I can see that. It's interesting, and it makes sense. This is healthcare. You all have mentioned clinical shortages.
Yes.
What about the rest? I have been recruiting for a finance director for 9 months now. I cannot get some. I have got, literally, with a $40 million organization, I've got a finance staff of 1. It's impossible. I can't get people. Anything else from non-clinical? Are you having issues or any ideas?
Do you require them to come into the office?
I'm flexible. I want them into beginning for orientation, but I have absolute flexibility.
Yeah.
So some of that we've had to change some of our practices and behaviors for the accounting staff, where we're now hybrid. And I think hybrid, it took a pandemic in order to get finance to go hybrid and some of the non-patient facing services, because the mentality is if you have a patient in a bed, you're here to support the frontline staff, right? And that's just been the mentality. But in order to compete with some of the IT firms that are out there, you've really had to be a little bit more flexible with some of the non-facing individuals, to where just to get somebody. I've even considered going fully remote, just to plug some holes on the non-clinical side, which HR, even myself, never would have thought it would have been possible. But now with Zoom, it makes it a lot easier. Instead of the old Citrix phone that you had to dial the 20 digit number, now it actually calls yourself,
Yes.
and you don't have to touch a button anymore.
Yeah, I have fought being a multi-state employer because all of my services are in one state, but I am actually a multi-state employer because I do have remote workers in other parts of the world. Mostly in the U.S. There's some that we contract with out of country, but most of my employees are in Washington State. But I have a few, and we're actually opening it up because, like you said, the pool in rural America is pretty small. I happen to be in rural Washington, and there's a lack of some high quality folks in a small town of 20 or 30,000 people. So we are opening up a lot more in remote work in all the states in the U.S. and seeing what we can find. It has changed. I'm not a remote worker, favorite type person. I prefer in person, but the reality is you're going to have remote workers.
And I think, we certainly had to learn how to do that, right, during the pandemic. And my HR director, who I assumed would always have to be an on-site person, looked at me one day and she said, "We have 20 sites. I'm sitting in the central office. I'm not on site for anyone except you." And
Right.
she's right. And she's right. And you know what? And she has a 40-minute commute every day. She's far more productive. She's working from her home, and she goes as she normally would to the sites as needed.
Right.
Yeah, we have found that here too. For the non-clinical and some director levels, the first question is it hybrid or is it remote?
Right.
And, to what Gary said, prior to COVID, that wasn't even a thought. 25 years ago, I never would have thought to ask to work remote.
Right.
And now it's actually a question when people come to interview, is it in the office or is it remote? Personally, I like being in the office. I don't like being remote. I like being around the people and stuff, but for some people it works. And, we've adjusted for that in order to try to hire. Like, we're looking for work-life balance. So we have actually adjusted that for people, when they come in. Yes, we, like Susan, to what you said, you got to come in, you got to get oriented, you got to understand it. But then after that, as long as you're getting the job done, doesn't matter where it's at. I do have a couple of people who do work remote. So,
Yeah.
and it's working.
Yeah, I know a company up here in Washington, their whole treasury and finance department was in an office building. They sent them home during the pandemic. They sold the office building. They're never going back to the office.
Yeah. Well, why do you carry that? Talk about waste elimination. You're paying rent on all this even my office. 50% of my billing staff now is remote. My office is too big. I'm paying rent every month. I need to look at that. Thinking of that category of waste elimination.
Yeah. We took our corporate office, which only had 4 people in it at the time. I've converted it into the business office, and we relocated the corporate staff into another location, which was much smaller and fit their needs. And, you just repurpose things as they come up. And just, I don't need a big corporate office. Let's just move into another location and make that building useful for somebody else.
Exactly. I find it funny that, people, you're right. I think Sandy's right. It's a question now. In fact, you have to put it when you're advertising remote, or hybrid options. But I bet all of you, if I asked you, even pre-pandemic, you were probably available remotely any hour of the day or night, right? I mean, I remember getting a call at 2 a.m. when I was in Sri Lanka because the doctor didn't know I was in Sri Lanka.
Mm-hmm.
So the concept of remote has changed. Now it's almost a necessity, but I bet you, if I asked you, for those of us who've been in healthcare long enough, we've been remote workers after hours forever, right?
Oh, yeah.
Yes. I actually had COVID and spent 10 days at home working.
Yeah.
No symptoms, just a positive test. Okay, you're going to stay home and you're going to keep working and do all the stuff you did anyway. You're just not in the office.
Yep.
Right. Anyone have anything else to add on labor?
Just to go back to what Gary had said, I don't think I'm ever going to see contract labor rates pre-pandemic. We are paying $60 to $65 an hour. I'm at 74 is the lowest I've been able to get back to. I don't think we're ever going to go back to 65. I think that's kind of the new norm.
Yeah.
I mean, I'm paying contract labor and it's not clinical. I have a temp agency to help with finance because I don't have anyone. I need someone to, enter things into the accounting system. I need to get my payroll out. I need to do those things. And it kills me. And that's when I try to help and they tell me that I'm causing more trouble. But anyway.
Yeah, I will say on that end, Susan, for accounting work, I've seen accountant salaries go up like 40%. They're hard to find, and the expenses gone extremely high. So there are shortages in other areas. Yeah, it's kind of all over the place.
Ken, I see you've unmuted. Yep.
Yeah, sure. I've got a few things to add on labor. Uh, you know, uh, During the pandemic, I was in Chicago at a safety net hospital in downtown Chicago, and we were spending about 2 million a month or so on contract labor. Worked hard to try to make some kind of impact on that, but they never really did find a lot of momentum. And then I transitioned out of downtown Chicago into a hospital in rural Texas. And then when I got to rural Texas, they had zero contract labor, nothing. I think we have one contract labor nurse and labor and delivery, and that's it. So, yeah. And then I think we have a few a few foreign nurses, but they're not anywhere near a contract labor rate. And one thing unique that they did here, not unique, a lot of hospitals did it. They would have, their own little internal contracts that the hospital gave out to clinical staff at a much lower rate than they were paying the agency. So they're able to cut out the middleman, that agency, and kind of keep it in house. And even then, I think we've whittled that down to maybe just a handful of internal contracts. So really, downtown Chicago, 2 million a month, rural Texas, hardly anything, and not a lot of the nurses in the community in rural Texas wanted to take travel assignments or leave the market, and so that is what really put pressure. Is that your homegrown nurses or nurses that are in your community were taking travel assignments to go out of your market, and that's what put the pressure on the supply and demand. But there was never really an exodus of nurses from the local community here, so it never really impacted quite as much as it did in a place like downtown Chicago when I saw it there. And then to your point, Susan, the non clinical folks are hard to come by. In Chicago, at the safety net hospital, I had a constant turnover of finance staff. I couldn't keep any body in the finance area. And you're right, the rates were going up each, for each new hire I had, and some of the large or very, very large publicly traded health systems I've been with, a lot of that finance function has been, outsourced or offshored or centralized. So I don't really, our staff at a hospital in rural Texas, since it's a part of a national company, is not very, very slim, but very productive. And the need is not quite there since there's so much centralization. So I think, in the future, as things get, more systems consolidate, you'll see a lot of centralization or offshoring to, India or the Philippines for those kind of roles. So that's my take.
So before we move on from cost cutting, I just want to see if there's anything you want to add non-labor related. Is there anything you're doing to look at other cost containment activities? I can tell you that, again, we're not owned by Trinity, but the Trinity Health Systems took hard looks at standardizing certain pieces of equipment, like implants for orthopedics and things like that, just to create some efficiency and cost savings. Is there anything else going on in your hospitals, non-labor related, that where you're trying to eke out some efficiency or leanness?
Sure. The constant always looking to do better, always looking to standardize and, try and drive out variation. That process has been ongoing for years in healthcare. So I don't, nothing specifically new in regards to that, but just the continued, looking to do better.
Anyone else?
I think, you look at your major cost buckets would be supplies. So, supply initiatives have been around for, 20 years with, GPOs and that kind of thing to push down the supply costs. So, my challenge is when I hire on new physicians and procedure areas, they want to, use the most expensive, the latest and greatest things. And so, that has some, kind of education and that kind of thing along with it to see if we can't get things cheaper or transition them over to a cheaper device or whatever. And then what I've seen is medical specialist fees, contracted physician services like your ER and the pathology and whatever you contract with, with the cost overall and the labor going up, the costs that they're charging for those contracted services are going, up as well. And that's hard to do because you have to have an ER group running your ER, right?
Well, and you have to have, I don't know if you pay, like I'm on the receiving end of this. I have PSAs with my hospital for call coverage in order to maintain their trauma status. They need to have, a urologist on call at all times. And the fact of the matter is, I can't afford to have someone doing something that isn't in the office or doing procedures. And so my opportunity cost of having them be at the hospital has grown.
Mm-hmm.
And so I had to go to the hospital and say, we need to up these contracts. Otherwise I got to pull out. I can't afford to be there.
Yeah.
So I think you're right. I think some of these arrangements are getting more expensive for you guys in the hospital.
Well, and I think the No Surprises Act going out is really going to impact the ER side mostly. It's going to cost hospitals more to have ER staffs doing it because most of them now have to be in network or at least have to disclose that they're not in network. That's going to raise the cost of staffing. Especially in Texas. I know, when I was in Texas, Blue Cross of Texas actually paid more to out-of-network providers than they did with contracted providers. So why would you be a contract provider? And now all of a sudden you're being slammed because you're out of network and, well, you're going to take a significant rate reduction to contract with them now. And as a ER group, you have a certain cost in order to provide the service, and you have to have an ER to be a hospital licensed in the state. So there's things that force you to raise your cost of doing business.
Yep. So let's get off of cost containment. I hate that part. Let's talk about strategy. Let's talk about growth. Tell me what you are doing to look at improving margins by gaining market share or going into new markets or starting new programs, or what are the strategies you're using? Because you're never going to win if all you can do is cut costs, right?
That is true.
You've got to grow. And I believe that firmly as a non-financial strategic person, you have to be looking for what your growth is. But like Max demonstrated, you have to have exit strategies too. So you try something new, it doesn't work, or you need to cut some beds, you need to have exit strategies. But talk to me, whoever wants to go first, tell me what growth strategies or new programs or market capture, what are you doing out there for that?
Yeah, I can start, unless you guys want somebody else, but we've recruited 6 new physician providers to our hospital in the last couple of months. We have 2 oncologists now. Before we had locums. That's going to save us $1 million a year and provide better service. We've never had 2 of those providers, medical oncologists. We recruited a new orthopedic surgeon. We haven't had one of those new guys in probably 3 years. He's been on site for a couple of weeks and he's already doing surgical cases. He's quite busy. So there are opportunities to grow the right kind of business. So it is interesting. We've been looking for a general surgeon. We'll probably land one of those guys. So it's opportunity to me as a CFO side, proceduralist kind of guys that do procedures always do better in hospitals financially. The medical side, not so well, right? Nobody wants to pay for medical care that is constant, never cure, chronic disease. Those are always paid lesser than on the procedural things that you can actually fix something and move on. So, we're always searching for opportunities to grow procedure-based services. We've hired 2 new GI doctors. We're the only hospital in the county that actually has board certified GI doctors. Those are fairly new to our service. The one guy is doing 300 cases a month. So there is volume to be done, and there's market out there to be had, and you just have to find the right mix.
One of the things that we're doing is kind of getting off our hospital footprint and going out into the community, and we're opening, off sites and, trying to get more outpatient because in New Jersey, Horizon's trying to get rid of the inpatient and try to make it more outpatient based. And how can you be how can you take care of these people before they get into an inpatient status? So there's a Horizon program that tries to not reward, but they pay you to take care of them on a outpatient level before they become inpatient. So what we've been doing is we're trying to grow our outpatient departments. We're trying to grow our ambulatory care center. We're trying to take it off. We're opening up off sites. So we're not just on this footprint because we have a lot of competition. There's 4 or 5 great hospitals in this county along with us. They're all great. So we're trying to get out into other towns where maybe they don't know about us. Now they're seeing us, they're seeing our name, and hopefully can attract them in for lab, radiology, same day surgery procedures. We just hired a wonderful physician recruiter who's going to be going out and trying to get us oncologists, cardiologists. We are looking at business, we're looking at business plan. What's the ones that are sustainable, to Susan, what you said, like that they work. So we have a 5-year strategic plan for, these are the doctors we're going to bring in each year, make sure they work, make sure it works, make sure they know how to use the systems, make sure, that we get a good rate, that they get a good rate, and, get the patients here. And, a lot of it is patient satisfaction, word of mouth. If they have a good patient experience, they're going to want to come back. So we invest a lot in, patient experience and making sure our patients are cared for.
Right. And I'll just add one more thing, Susan. In addition to that, we're a hospital system, but back in 2022, we bought a dental practice and a dentist, and we're into the dental side of the business. And so, it's now you have behavioral health, dental, and acute care services, all kind of wrapped up into one company. That dental practice goes into a rural health center and gets paid an all-inclusive rate like the rest of our rural health center visits. And instead of getting paid $50 for Medicaid for a dental visit, you're getting paid $500 for a rural health center visit. So it makes perfect sense. And it was interesting. We had an RHC just kind of sitting around not being real active. So we bought a dental practice and then moved a rural health center on top of it.
Yeah, that's smart. And you're bringing the services to the patients that they need, right? And you can get them into everything else.
Because there are no adult Medicaid dental practices in the state of Washington. They're very hard to find.
There you go. Well,
So I think there's a question that I'll try to answer about what outpatient ambulatory expansions do you all feel might be most worth the initial investment? And so in terms of like some of that outpatient ambulatory space, a lot of times it's trying to, on the doctor side, it's really trying to capture the market around that PCP business, that primary care physician is key to like referral business, right? Back into the hospital to some of those service line and procedural areas that Max was talking about. In terms of like a building that we've seen some success in that outpatient area, there's always ambulatory surgery centers, right? That is good to invest in. We've had some success with some of our freestanding emergency departments where it helps declog some of the ED space that we have in our primary hospital, and some of the lower level ED services are able to be seen at some of our freestanding departments. So as Sandy was talking about, getting out into the community that maybe your hospital's not in, that's helped us capture some of the market space. And then if they are too critical, we will then transfer them back into our primary hospital. And so to get some arms into the space at a quicker rate to see a patient within 15 minutes, like we've seen some good success with some of those freestanding emergency departments in some of the different markets.
Do any of you have, this is a near and dear to my heart, do you have relationships with the private practicing physicians in your service area? I will tell you, one of the things that Trinity does that is very important to us is they have invested in we have predominantly private practice for primary care in my market. They do not own it. And they have, they've tried to buy us and we've said no, but rather than fight with that, they have decided to partner with us. So they give me forgivable loans and income guarantees to bring in new primary care, not the specialty care that truly is competitive. But they've also, and we're still working through this. I'd be curious to know if you guys are doing this. Your goal is to fill beds, right? And to fill the OR and do that. My goal is to keep as many people out of your facility as I can, because I get paid based on high quality, low cost care in the appropriate setting. So if I can have my urologist do that procedure in the surgery center, I'm going to have them do it there rather than the hospital. How are you partnering with the physicians, if that's even true in your situation, to manage that balance?
So I would say like there's different joint ventures that you can do with some ASCs to help drive that partnership, right? With some of those procedural doctors. This way, everyone gets a piece of the pie, right, at the end of the day, and have those relationships so that they're performing the procedure in the appropriate setting, but also you're able to capture that patient's journey throughout the process. We've seen some success by working with physicians on getting everything mobile, where they can access our charts a lot easier via an app, so that they can check on the patient if they get admitted for some reason to the hospital, right? But they can see what's going on via an app. And so trying to get things digital is key to, I think, driving that connection with those physicians that we've seen work in different settings.
I mean, the whole premise, it's better to have 50% of something than 100% of nothing, because I'll tell you from the private practice side, we're going to do this. We're going to open surgery centers. We're going to open imaging centers. We're going to do that stuff. We'd rather do it in partnership with you. I'm a CON state, so I don't want to have fight you on a CON, but I need a strong hospital, because I do need an ER, and I do need a place for the patients to go. Mm-hmm. So I'm always curious to see how hospitals' attitudes. Some are, we're going to keep it all, versus partnering with the private community.
Yeah, our situation here is a little different. We employ the vast majority of our own physicians in services. There's probably 90% of our businesses with our own employed docs.
Ken, are you mostly employed, or do you have private practice where you are?
Yeah. I had to unmute there. Yeah, so mostly it's independent physician practices. Now we've hired a few employed physicians in the specialty area, like cardiology. So we brought on 3 new cardiologists, and we do have a lot of income, or relocation agreement guarantees, or relocation agreements with the independents to recruit physicians into their practices. And that's gone pretty well. And we do JVs on certain things with them. So we definitely try to keep the independent physicians aligned with our facility and do partnerships with them. And actually, it's gone really well. You know, a lot of the independent physicians are very, very loyal to our hospital in rural Texas. And you know, we try to be the preferred hospital of choice. And you know, there's only one other hospital in our county, but I think we do really well in that regard. You know, and we've tried to grow services at doubling the size of our ER, you know, just making ourselves available for those independent physicians and reaching out and that kind of thing to make sure they're engaged. And of course, to your point, Susan, you know, it's in your best interest to do as much as you can inside your practice. But some things, you know, really have to come to the hospital rather than the practice. But we try to be a good partner with those independent doctors to make sure that there's a seamless flow to take care of the patient and the appropriate level of care.
What's it like in New Jersey? In terms of your private versus, and I think is City MD big where you are? I guess they're Village. They were bought by Village.
City MD not around here. They are big in the city. They are big in the city. We have a lot. We actually go through one of the schools, one of the medical schools that does all of our private practices, does all of our specialties in our ambulatory care center. We do have our psychiatrists are employed, and our hospitalists are employed. Our ER docs are independent. We are looking at joint ventures with physicians and buying their practices and trying to get them on board. That is our goal that's one of our strategic goals for 2024. Right now we don't have anything yet, but that's why we're trying to, you know, we're trying to put docs out on these offsites, kind of like a City MD, you know, not urgent care, but like you know, primary care, anything you need. So, but yeah, we are looking to do that for 2024.
As we get close to wrapping up, I'm going to ask each of you to address this question and tell us how you, as a leader now, not in your role as director of finance or CFO, but as a leader, how do you gender the support you need to move forward with these projects? Give us your 1 minute of wisdom on how to lead through these difficult times.
I guess, you know, for me, it's just, you know, the natural thing, you know, you'd step up and, you know, try and be a leader and be open and listen and try and understand what the issues are and the challenges. And then, you know, I've always considered myself a creative problem solver, you know, always thinking outside the box and trying to figure out what we can do. You know, I talk to other people and it's like, how did you shut or close down services in order to avoid contract labor? Well, okay, you had the conversation, made the decision, and then you just go do it. And it is that difficult. It's like, okay, now that we decided to do this, let's just go make sure it happens. And you have to pursue that and, you know, follow up and make sure that the vision actually gets implemented. You know, roll up your sleeve and, you know, go make sure it gets done.
The Nike symbol, just do it, right? Okay. Gary, what's your parting words of wisdom with regard to making these things happen?
My go-to is usually follow the data. I have data trust issues. I don't have spousal trust issues. I've been happily married for 10 years with 4 kids, but I have data trust issues. And so making sure that you have, you know, you're looking at those service line margins. Is it, you know, the cost accounting is one way to view it, but making sure that it's encompassing the actual cost versus an allocated cost. And, you know, there's a couple different ways that you can try to really tease out, all right, what service line, you know, do I need to go after to get, or which one do I need to sunset? And trying to make sure you analyze it appropriately is key to making, I would say, any new investment and then kind of keeping, where you drew a line in the sand and doing look backs just to make sure, all right, did that work, or learning from being able to learn from those mistakes.
Excellent. Who's up? Sandy.
I think for us, I think the big thing is transparency with your management team. Make sure you give them the data, make sure, if you're holding somebody responsible, you got to make sure they have all the information and the tools they need to be responsible. To what Gary said, business plans, ROIs, if we're going to start a new program, like you said, what are the direct costs? What are the indirect costs? You got to make sure you vet it. And you got to make sure you have the right, everybody at the table. It can't be two people making a decision and then it impacts eight other people. So, break down your silos, be transparent, make sure everybody has the information so that, everybody can make an informed, educated, good decision.
Excellent. Ken, any last words?
Sure. I like what Sandy, Max, and Gary mentioned as far as their perspective. But for me, number one is what are we doing about it? So you can have all the information and analytics and that kind of thing, but really it comes down to what are you doing about it? And so you make sure you communicate that to your team and to all your staff. Open communication, make sure everybody's rowing the boat the same way, and everybody's on board and going toward a goal. And as leaders, we have to be, pushing that along, and showing the folks where to go, where to row, how to do it. So that's my take, is really, what are you doing about it? What are the top things you're doing to make a difference?
So I love these. And if I can just summarize the end of this, part of the pathway of success is understanding, analyzing, and following the data, and then figuring out what to do about it, communicating it openly. It's very important people know why they're doing what they're doing. And in the end, just do it. So I want to thank all of you very much for being part of this panel today on a Friday afternoon. Well, at least on the East Coast on a Friday afternoon. Sorry, Max. And taking your time to do this. I've appreciated your insights and I value them. And I wish you all tremendous good success.